Perfect. Let's make a start. Good evening, everyone, and thank you very much for joining the December and last session of Legendo in 2025. We are coming to the end of the third year that we've been running the journal clubs. They have been, we think, very successful. We have had, I think, with the exception of two sessions, running this every month at 6 p.m. On the 6th of every month, London time. And the team behind putting everything together has been the CIMIG London team. Currently, Oscar Barnick is coordinating everything and is here with us tonight to present some of the papers. Mr. Mondelli, who is now a consultant colleague in Guildford, is with us tonight. And tonight we have two great guests from France. One, my very good colleague, Professor Arnaud Fauconnier, who I'm going to introduce properly in a second after Oscar has done the presentation, and then Dr. Yasmin Druish. I hope I'm saying the name right. Um, so we will have an interesting evening because I think we will have a little bit more time tonight to do more discussion and conversation. And for the audience, please feel free to message your questions, and maybe tonight we will be able to actually invite some of you to discuss in a little bit more detail because we've had feedback that people want to be more involved and do discuss. A couple of housekeeping things to say. One is to thank Carl Storz UK for their support in organizing these. They are our sponsors for the journal clubs, and this is a joint venture with European Endometriosis League. And we're grateful for the EEL members who have been helping in the coordination as well. Finally, the important thing that we say every time we run the journal club, because we have sometimes people on the Legendo who may not necessarily be clinicians, and some patients sometimes join us because it's free to join for everyone, is to notice that the way research works and the way evidence-based medicine works is that one scientific paper does not have all the answers. And the fact that we present something here, either as a featured presentation or the small presentation, does not mean that this is the answer and this is going to be the truth or that we agree with it. It is one paper, one study, and together all of these are pieces of the jigsaw puzzle. We will discuss them, we'll review them, but every little helps. We need a lot more research in the field of endometriosis. So with that, and with all the thanks to the team, to the CMIC team for the whole year, Oscar, you start with the small presentations. We'll have two papers that Oscar will present. Then I will introduce Professor Fauconnier and Dr. Druish, and we'll then go for the presentation.
Thank you so much, Mr. Kazali. And hello, everyone. Good evening. So I'll be presenting two small papers of very similar design and very similar treatment modality. You'll forgive me for looking at medical treatments rather than surgical treatments tonight, but we'll come on to the surgical treatments after my talks. The first paper is the 2-year efficacy and safety of relugolix combination therapy in women with endometriosis-associated pain. This is the open label extension study of what was the Spirit 1 and 2 trials. The relugolix combination therapy is what we here in the UK know as Ryaco or Ryco, depending on how you like to say it. And this is the open label extension study looking at the longer term treatment effects. So in terms of the study design and population, you can see here on the right-hand side, the original three arms of the Spirit 1 and 2 studies were placebo, relugolix combination therapy, and delayed relugolix combination therapy, whereby patients were given just the antagonist for the first 12 weeks, and then they were given the combined relugolix and HRT treatment for the rest of their treatment. So three different arms. What they did as the part of the long-term extension was to take all three of these arms and give them the relugolix combination therapy for a further amount of time, up to 80 weeks exposure, which totaled 104 weeks, including the initial Spirit 1 and 2 trials. As from the previous studies, the participants were all premenopausal 18 to 50-year-olds with histologically and surgically confirmed endometriosis, and they all had moderate to severe dysmenorrhea and non-menstrual pelvic pain scores. There was a high baseline burden of disease with 84% prior to surgery and the mean age of 34 years, many of these patients exhibiting long-standing disease. So we've discussed the intervention. The primary endpoints, we're looking at the proportion of responders for dysmenorrhea and non-menstrual pelvic pain at both weeks 52 and week 104, which they called end of treatment. And a responder was deemed as someone who had a clinically meaningful NRS reduction of greater than 2.8 score for dysmenorrhea and greater than 2.1 for the non-menstrual pelvic pain without an increase in analgesic use. Looking at the outcomes from their study, there was a sustained pain response. And in the dysmenorrhea, there was a response of 85%. Non-pelvic pain responders at the end of treatment was 76%. And the mean dysmenorrhea went from 7.4 to 1.2 at weeks 52 and 104, which was an 84% reduction, which they classified as severe to mild in terms of symptom relief. In terms of the non-menstrual pelvic pain, the scores went from 5.9 down to 1.8 by week 104, which is a 69% reduction. There was minimal to no pain achieved in many patients. 95% scored dysmenorrhea pain scores of less than or equal to 1, and 70% scored non-menstrual pelvic pain less than or equal to 1. Dyspareunia and overall pelvic pain showed similar sustained reductions over 104 weeks compared to the initial Spirit 1 and 2 studies. And the EHP 30 pain domains showed majority achieving clinically meaningful improvements of at least 20-point decreases, and pain-related functional limitations improved and remained stable over the 2 years. So the graph on the right shows dysmenorrhea curves at first. So you've got your placebo moving on to relugolix combined therapy at the end of the 24-week initial study, and you can see that there's a marked drop in change from baseline. And you can see with the relugolix combination therapy and delayed arms that drop happened much earlier on in the Spirit 1 and 2 trials, but it was very much sustained over the prolonged extension to 104 weeks. In terms of analgesic and opioid sparing, 7% were analgesic free at the baseline, and 75% were analgesic free by the end, and 61% were opioid free at baseline, up to 91% at week 104. The second graph shows the reduction in non-menstrual pelvic pain. You can see this is slightly less meaningful with regards to the placebo versus relugolix arms, but nonetheless sustained, and the dyspareunia similar. Lots of clinicians will have concerns over the safety profile of using these for long-term treatments, in particular surrounding bone mineral density. And the adverse effect profile over 104 weeks was deemed consistent with the initial 24-week studies, and there were no new safety concerns. The common adverse events included headaches, nasopharyngitis type symptoms, hot flushes, thrush, and UTI symptoms. Serious adverse events and treatment discontinuations were uncommon, and there were no treatment related deaths. I'm sure everyone's pleased to hear. In terms of bone mineral density, so there was a small, less than 1% mean lumbar spine decline by week 24 in the initial studies. This then plateaued from week 36 to week 104, and the total hip bone mineral density remained stable or, in fact, slightly improved over the 2 years. So, this suggestion is that the initial drop is something that is not then sustained, and actually there's even a small improvement due to the add back success, and that mitigates the long-term bone mineral loss, which is really important as we're starting to see the usage of these being picked up so widely, and we're starting to see longer term treatment, and I think it gives us a great safety profile to work with. In conclusion of this study, the bleeding profile menstruation did show amenorrhea. I think it's a useful thing to be able to tell patients 80% by week 52 and 77 by week 104, so very sustained, with a little bit of spotting as those reporting residual bleeding. And then those returning to menstruation after stopping is 90% or more within 2 months from stopping treatment. So the clinical implications are that relugolix combined therapy offers a long-term and reversible oral medical option for moderate to severe endometriosis-associated pain, that we've got meaningful and sustained improvements in pain and function with marked reduction in opioid and analgesic reliance, and that the bone mineral density stability supports using these for longer lengths of treatment time compared to the traditional GnRH agonists. Although the drug companies do still recommend monitoring with a 1 year DEXA scan to be sure of no marked bone mineral density loss.
Okay. Thank you very much, Oscar. I'm assuming this was a study funded by the company.
It
Yeah.
was, yeah,
Okay.
in
So it's
collaboration with Oxford University.
Yeah, so that's important to keep in mind. That
Absolutely.
doesn't disqualify the
No.
study. But it's important to mention. A couple of things that come to mind, and I would wonder if Professor Foconia has any comments on it as well, is to remember that, first of all, one thing that I really can't understand in the whole of the series is when we say that menstrual pain has reduced, and we're not comparing with another medication that gives amenorrhea,
Mm,
why do we think it's any different to any other medication that gives amenorrhea? Because we don't need an expensive RCT to tell us that the period pain will go down if you stop periods. So that is just the logical thing. Yes, the pain goes down because the period went down, or is it better? I'm not sure if there has been ever a non-inferiority or any comparison with other medical therapy that we've had. I don't know if you are aware of them, Arno?
Yes, I agree totally with you. I would precise some of the tips, methodological tips. First, there is no one scale to measure pain of endometriosis at the present time. They use several scales. So they measure dysmenorrhea, then non-menstrual pain, then dyspareunia as previous RCTs. So the problem to see what exactly happened to the woman, what is the feeling of the woman? Is it really better or just no more dysmenorrhea, but having non-menstrual pain as a great impairment of quality of life? I think in this study, all of the two outcomes are going together. Dysmenorrhea first, and then other are going better. So, in my opinion, it's working. It's working on dysmenorrhea, but also on other pain symptoms. But it's like a unique measurement of the intensity of the pain. So, next time, yes, should think about that. The second thing you tell is really true. That is, what is exactly the place of this new treatment? So you have a treatment who are treating pain of endometriosis, moderate to severe endometriosis. So what will you choose to treat a long time? So you can use uh, contraceptive oral pills with a great number of success, or you can use the Dianogest, progestin, but you have no comparison in between the different possibilities. So you're right. What is this RCT does not break or with something really new or a solution for patients who have no solution. If you don't want to have surgery, you have many solutions, and this one is another one, another solution. But we don't have data on long term. That means like progestin problems, meningioma, or things like this, or vascular problems like we have with contraceptive oral pills. So we will have to wait to declare that this new therapy is better or inferior to the other one. So it's my opinion.
Yes, yes. No, I agree. And just to add that, generally speaking, medical treatment for endometriosis, just to share my opinion on it, and I know that many may not agree, there's a lot of strong feelings about what's the right way of treating endometriosis, particularly for people um, who don't deal with the disease every day as a clinician. They may expect that doctors should have the answer that, this is the right treatment, this is the wrong treatment. The reality is that both medical treatment and surgery are tools in our toolboxes. And as endometriosis surgeons, we need to put the patient in the center of decision making and considering their wishes and their expectations, choose the right treatment. Sometimes that could be medical management in conjunction with surgery. Sometimes it would be surgery and won't need medical treatment. And therefore, each case is different. The reality is the patients should know that with medical treatment, symptoms can be controlled sometimes. But the reality is that with particularly deep endometriosis, the disease does not go away. It's the symptoms that will improve according to this study. Okay. Thank you very much, Oscar. Let's go for the second one.
So, so along an extremely similar line, and I think it's useful to look at both the different treatment options available in this class of drug because I think we're using them so much more than we were. So this is the Linzagalix study. So Linzagalix is therapy versus a placebo in patients with endometriosis-associated pain, and this was a prospective randomized double-blind phase 3 study. So this was Andrew Horn's group and published in Human Reproduction 2024. So for those of you, I'm sure everyone is aware, but Linzagalix is an extremely similar peptide to rilagolix, and they're both slightly newer versions of the L-agolix that's used in the US. There is a small difference in linzagolix in particular that we'll look at here, in that they are able to give a slightly more dose-dependent effect. So the inclusion for this study was 486 women with surgically confirmed endometriosis and moderate to severe endometriosis-associated pain. You'll see a great similarity in the way that these studies are designed and the outcomes that are reported. The intervention arms were 3: placebo once daily for 6 months, linzagolix 75 milligrams with no add-back therapy, and linzagolix 200 milligrams with add-back therapy in the form of estradiol 1 milligram and norethisterone 0.5 milligrams. So the primary question for this study was at 3 months, do the 75 milligram or 200 milligram with add-back provide superior improvement to dysmenorrhea and non-menstrual pelvic pain symptoms versus the placebo with a stable or decreased analgesic use. In terms of the method, this was multinational, multi-center, prospective, randomized, double-blind, double-dummy, placebo-controlled phase 3 trial, 91 sites worldwide, and 6 months treatment with 6-month follow-up. Inclusion highlights essentially
And
reproductive age.
sorry, Oscar, I'm
Please.
assuming again funded by drug company.
Yes, correct.
Yeah.
Sorry, I should have
Okay.
really, that's a strong caveat with both papers. Laparoscopically confirmed pelvic endometriosis within the last 10 years. In terms of the co-primary endpoints at month 3, they were looking at the proportion of dysmenorrhea responders, the proportion of non-menstrual pelvic pain responders, and they defined these slightly differently using the VRS scores over the last 28 days with stable or reduced analgesic use as well. The key secondary endpoints they looked at were changes in these scores, EHP30 domain changes, days with moderate to severe pelvic pain, and again, analgesic and opioid use, and any of the adverse outcomes, bleeding, spotting days, etc. In terms of safety endpoints, they also looked at bone mineral density, any adverse events, treatment discontinuations, and they monitored some of the liver enzymes, lipids, endometrial histology, and return of menses. So outcomes at 3 months. So looking first at the 200 milligram with add-back versus a placebo. As you'd expect from what we've just spoken about as well, dysmenorrhea rates were vastly different, 72.9% response versus 23.5% response, and non-menstrual pelvic pain 47.3 versus 30.9 with an odds ratio of 2.01, statistically significant. When looking at the 75 milligram option versus placebo, dysmenorrhea response was lower at 44%, and non-menstrual pelvic pain improved, but not to a significant effect. At month 6 versus a change from baseline, dysmenorrhea rates in the placebo arm were sort of around 0.66 versus scores of 1.1 for the 75 milligram arm and 1.83 in the 200 milligram arm. And you can see similar effects to non-menstrual pelvic pain. So overall, the pelvic pain at 6 months was reduced significantly in the 200 milligram arm, but not significantly in the 75 milligram arm. Other pain domains and quality of life, so dyschezia improved significantly in both groups versus the placebo, and dyspareunia improved to a small non-significant improvement.
Sorry, Oscar,
Yeah.
the reduction is the number of points in VAS score?
Or
That's your
in VRS
understanding?
score. Yeah.
Okay, okay.
Yeah.
So do we think it's clinically different? Just looking at those numbers, sorry to interrupt
Yeah,
you.
please.
So in 200 milligrams, on average, the mean reduction in VAS score has been 3.3
Yeah.
points versus placebo 2.1 points.
Yeah,
Is
exactly.
that really a clinically significant difference? I know it's statistically
Mm.
significant, but anyway, maybe we can discuss at the end.
I think that's a really interesting point. I think in the graph, it maybe looks a little bit better.
Yeah, graphs always
They
are
skew
drawn in
things.
a way that looks better. But yes,
No, it certainly looks better for them. So that's your dysmenorrhea graph, your non-menstrual pelvic pain graph, and that's 3 months and 6 months essentially left and right. Um, in terms of safety and reversibility, bone mineral density, um, at 6 months, any treatment emergent adverse effects were very similar, so around 46% for placebo and 75 milligram arm versus 56.8% in 200 milligram arm. Most of the events were mild to moderate. There were less than 3.1% severe across groups. Common findings were headache in 8 to 11%, hot flushes and fatigue. And in terms of sort of event-related discontinuation, this was highest in the 75 milligram arm and fairly similar placebo to add-back arm. The bone mineral density mean percentage change at 6 months was less than 1% in all groups. And the majority of women had no change or less than 3% change in bone mineral density. And there was more than 8% loss, which was very rare in all three arms. The hormonal bleeding profile and reversibility. So both doses of linzagalix maintained estrogen largely within the 20 to 60 picogram sort of therapeutic window, and the placebo, they were all higher. Bleeding days were reduced, particularly with the 200 milligram arm. So that was roughly 2 days in 28 versus 4.5 in the 75 milligram arm. And generally, menstruation resumed about 4 to 5 weeks after discontinuation. So I think it was to be expected, really, that a higher dose suppressed estrogen to a stronger degree and you had less bleeding. But interesting to see that the bone mineral density loss is fairly similar between the two arms at a 6 month treatment use. So just to conclude this study, in terms of the 200 milligram plus add back therapy, this is had the strongest evidence of the three arms for rapid and clinical meaningful improvement in dysmenorrhea, as we would expect, but also non-menstrual pelvic pain, dyschezia, and overall pelvic pain. Quality of life scores with minimal bone mineral density loss, and the authors view it as an attractive second line for moderate to severe pain after combined oral contraceptive or progesterone treatment. In terms of the 75 milligram treatment option, they found it effective for dysmenorrhea, and by month 6, they saw that non-menstrual pelvic pain did improve with minimal bone mineral density impact. So there's a potential treatment option here with this for women who are unable or unwilling to take the add back HRT option, but there's no longer term comparative data. And again, what's really unanswered by this study is the comparative effectiveness and the cost effectiveness of this style of treatment versus our more widely used contraceptive pills, and versus the other GnRH antagonists, in particular relugolix that we've just discussed. And I think there really needs to be some form of head to head.
yes.
The only thing I can see from a clinical perspective is that this coming into the market will improve the cost of both drugs over time. They're extremely similar, and Ryko's slightly ahead in terms of their longer term data, but we can surely expect very similar 2 year follow-up data when they come through with that study. And it at least drives the cost down and maybe makes this more readily available for patients. But I'd be interested to hear your thoughts.
Yeah, I think very similar. My comments would be very similar too. it's good to have these in our toolbox and use them when other treatments have failed, when we need to do medical treatment. But it may be the fact that I haven't looked carefully enough into these studies, but I remain unconvinced that these medications are better than the already available very cheap versions of hormonal treatments that we have. But um, I think it remains to be seen. Arnaud, do you have any comments?
I have a question. Do you patient where already had contraceptive oral pills and or diagnosed and they failed? This first line therapy failed, and they were then included in the trial, all of them, or it was not precise or not the case.
I didn't see any mention of previous medication use, and they didn't stratify the improvements in patients who had had that. I think there's an assumption lots of them would have been on something in that time if their study inclusion was 10 years of
But
since.
that's an interesting, Oscar. You make a very important point because I think you're right in saying that most of these patients very likely would have been on some kind of treatment. But
Mm,
why can't we see that information in the analysis?
mm,
Are the patients happier than their
This is a
previous?
problem.
Yeah.
Yes.
I'm
Mm,
just having a flick
Yeah.
through again to see if I
Yeah.
can.
Sorry, oh no. Yes, you were going to say.
I don't know. It's an important
Yeah.
information, and if it's lacking in the paper, we should send a letter. But it's too
Yeah.
late.
Yes. Yes.
So
Um,
we cannot precise again the place, second line, third line,
yeah.
or what else. So it's we are waiting for um, post post marketing data. So
Yeah.
what happened for patient who use that medication? Because you will have doctor who will prescribe this, and what will happen with this patient? What will be the first clinical impression of a patient who receives this medication? Does it seems to work better than contraceptive oral pill? And secondly, we must ask for a comparison trial. So again, for again with contraceptive oral pill, and with
And I think this leads us very nicely to introducing you, Professor Fauconnier, because if anybody knows anything about trials and how to do research, it would be you. Hundreds of very high quality papers that have come out of your center and with your name. I remember, I've been practicing for a long time now, but even as a young doctor, I remember following your work and admiring your very high quality research. So, with that, we are particularly grateful and honored to have Professor Fauconnier, who is a professor in Poissy Saint-Germain. Excuse my French, bad French
no, it's
accent.
correct. It's
Yeah,
correct. It's
yeah.
Poissy Saint-Germain, exactly like that.
And he's also a professor at Paris-Saclay University. You will have seen his papers on various different gynecological topics. So when Arnaud was in London, we met in London. We were having a conversation about research, and he shared with me very kindly an interesting study that Yasmin Drouish has undertaken and helped with, and felt that she will be a good person to present this. So we're very grateful to you, Yasmin, who's a final year resident in obstetrics and gynecology. So Please, the floor is yours, Yasmin. I'm going to turn my camera off and I will leave it for you and Professor Foconia to lead the next 25 minutes or so that we have.
Yes, and if we have time, I will show you a quick study unpublished and who is interesting to answer of the problem of measurement and clinical measurement and so on. So
it would be great. Yes, we have until 8 o'clock your time.
okay,
So yes, please go
fine.
ahead.
Yasmin, it's your time.
You, you're seeing my slide? Is everything okay?
It's lovely. Yasmin.
Yes, we see.
Hello?
Yeah, if these are your slides, I don't know. We see the poster for tonight.
Yes, great.
Yes.
So thank you. Good evening, everyone. Thank you for having us. We are really delighted to be here today to share our work. We'll be talking about a rather hot topic in endometriosis. So success or failure of surgery for painful endometriosis, does it depend on the extent of the disease? First of all, surgery plays a key role in managing endometriosis-related pain with long-lasting benefits. As this randomized study shows, the improvement remains significant at 6 months with laser laparoscopy. However, we should keep in mind that some patients continue to experience residual pain. Secondly, there is a signal in the literature suggesting a correlation between lesions and symptoms. However, this prospective study highlights an important point. Even among asymptomatic women, visible endometriotic lesions were found in around 40% of cases. And in 100% of them, the lesions were either microscopic or very limited in extent. Finally, there is a correlation between the type of symptoms and the anatomical location of deep infiltrating endometriosis, as shown in this paper, with an association with dysmenorrhea and Douglas pouch involvement. So our reasoning started from a simple assumption. If endometriotic lesions causes pain, then their surgical removal should relieve the patients. But it's not always the case. As shown in this systematic review of 2021, about 20 to 28% of patients do not improve after surgery, and for now we don't fully understand why, or which subgroup of women will not respond. So we hypothesized that only certain features of endometriosis lesions are responsive to surgical treatment, whereas alternative mechanisms may underline other forms of the disease. So to address this question, we used data from the EndoCol cohort, a large French prospective multicentric database from 10 years, and we included 740 patients undergoing their first surgery for painful endometriosis. Before surgery, patients completed questionnaires on pain and quality of life. Surgeons documented the lesions and procedures performed using the revised ASRM classification, and 1 year later, about 531 patients completed the same questionnaires again. So about 72% response rates to the follow-up questionnaire. Then we used the patient global impression of improvement at 1 year to define responders, those who felt better or much better after surgery, and the non-responders group, about 28% in our cohort. Our first result is that surgery improves pain and quality of life. Indeed, responders showed a 4-point drop in pain and a 20-point improvement in quality of life scores. Then surgical outcomes are associated with specific lesion characteristics. In our adjusted logistic regression model, we found that certain factors were associated with better outcomes, as shown here, rectosigmoid involvement and deep bladder involvement. In contrast, minimal endometriosis and a very impaired quality of life before surgery were linked to a poor response. And these findings remain true after adjusting for other variables, suggesting that these factors are independently associated with surgical response. Similarly, the performance of digestive for bladder surgery improved the response to surgery, as well as cystectomy or adnexectomy for endometrioma. So, success of surgery does depend on the extent of the disease, but not only. We identified some factors linked to response to surgery. But how exactly do we interpret these results? First of all, surgery can be effective, and as surgeon, it's reassuring to know that. But our data highlight the importance of patient selection by considering not only the extent of disease, but also its impact on quality of life. We can better tailor treatment strategies and improve outcomes for our patients. And it also raises hypotheses about the causality of pain. Not all endometriosis lesions contribute equally to pain. We can distinguish two main profiles. First, we have pain with extensive and deep lesions. This often involves infiltration of the digestive system or bladder, and there is a clear anatomo-clinical correlation. In these cases, we see that the pain tends to respond well to targeted surgical interventions. On the other hand, we also have pain with minimal lesions and a significantly impaired quality of life. Here, the pain is largely mediated by indirect mechanisms, particularly central sensitization. There is often less of an anatomo-clinical correlation, and the management becomes more complex. And surgery should not be the first-line option for these patients. So finally, pain in endometriosis is a complex phenomenon involving multiple mechanisms that can evolve independently of the lesion over time. We think that the coexistence of limited lesions and severely impaired quality of life may reflect the presence of this lesion-independent pain for which surgical treatment is ineffective. And we should offer for this patient a better global and integrative management. Thank you for your attention.
Thank you very much, Yasmin. Very reassuring to see that what you found reflects what our experience says as well. That I think the people on the audience who are endometriosis surgeons would agree with me that we can always guess to some extent which surgery or which patient is likely to come back for the post-operative appointment with a box of chocolate or a thank you card, and which patient is unfortunately unlikely to do so. We're not always correct in that. In my experience, sometimes very subtle endometriosis can respond very well, and sometimes very deep endometriosis may not. But as a pattern, I have seen that, you know, when you deal with very severe disease in someone with very severe symptoms, surgery is often very effective, and they are going to be very happy. People who worked with me, Oscar will tell you, Ben has worked with me. At the end of an operation, I make a judgment. I say, this lady is going to do really well, or this lady, I'm not sure, you know, we'll have to work on the pelvic floor, we'll have to work. And just to give an example, if somebody comes to me who's had 5 previous laparoscopies, excisions by good surgeons, they've always found very subtle endometriosis and the pain is multifactorial, they have central sensitization, they also have other comorbidities and other issues. Unfortunately, surgery may not be the answer. Sixth surgery may not solve the problem. And I think this is as important as it is for us not to dismiss our patients' symptoms and concerns. It is also important we have a duty to our patients to do no harm, and when surgery is not likely to work, then be very frank and honest with our patients. Oh no, I think there is enough time for you to also share with us what you had.
Yes, yes. Your comment, I agree. My opinion since a long time is to explain that there must be a parallelism between symptoms and extent of the disease. That is, minimal disease cannot explain extensive symptoms. It's not enough. So it's kind of bon sens, comme on dit en français, as we say in France, bon sens. Um, and there is a conflict between me and people who are treating pain doctor, saying even a little piece of endometriosis may explain awful symptoms. I think when you do surgery, you understand it is not the truth. So if you take into account the placebo effect of the surgery. So I will show you a non-published data, but I think hopefully soon will be published about what you see before surgery on MRI, and then what will be the result 1 year after. So let's see. Up, you will have it here. Up. So it's here. No, it's not that. Sorry, I miss. I will show you what we have done on. Can you see my screen? Yes. We have here, you have three groups of patients having an MRI before surgery. We always have MRI in France before surgery, and MRIs and transvaginal ultrasound, and then decide to operate them to do resection of all visible endometriosis. So you have three groups. The first one with no visible endometriosis at MRI, but we have decided to operate them because we think it might be endometriosis anyway. This is the typical group. So you have on MRI typical image aspect of endometriosis, and then is intermediate, and we call uncertain. This is soft sign of on MRI, but we cannot be sure. So guess how many endometriosis lesions were found in the three group?
How many?
How many? Yeah. How many women had endometriosis in this group? For example, no endometriosis visible at MRI.
I don't know.
So 90% had histologically confirmed endometriosis. So great. So MRI does not count. You may have endometriosis. 90% of women symptom had endometriosis. In this group is 98% of endometriosis histologically proven, and this one is 95. So no real difference between confirmation of the diagnosis. But what will happen 1 year later? All have removal of endometriosis lesion. So you have the change of the endopain scale. I will explain you what is endopain scale, but it is a unique scale measuring the pain symptom as a whole. So it's very interesting because it gives you a scale unique, but in mixed symptoms. I will explain you later. So, and you have here what is called, you have clinical interesting difference. This is very important. When you use a scale, this is to answer to Shane, that you know what is the minimally clinical interesting difference, because you may have difference, statistical difference, but not interesting difference. So here you have the minimally clinical difference. And what you can say is that, as expected in the group of typical endometriosis at MRI, you will have a huge and great and of course significant difference 1 year after reduction of the pain score. And this was not the case in the group minimal endometriosis, in the group where MRI did not see endometriosis. So when you don't see endometriosis at MRI, don't avoid operation, because you will find endometriosis and you will have a placebo effect, and then the pain will go again further, and patient will say, my endometriosis has come back. So it's not the endometriosis who have come back, it is the pain. So it's very important to consider that endometriosis lesions are not always the cause of the pain of the patient. So MRI or imaging, what is important for me is to see something, to see a thing to remove by surgery before operating. There is another important point, is that the symptoms will be connected with the lesion you will see. If you see, for example, a lesion in between the bladder and uterus, you may have bladder symptoms, and it will work. Or if you have a nodule in the rectovaginal space, you may have dyspareunia or dyschezia, and it will go well after the surgery. So this is it's a little study. It's about 200 patients, so coming also from the Endocal database. So this must be replicated, but you have the chance to have a great study, RCT, in UK at this time, and I think it's better, but I'm not sure. And he's randomized woman with no visible endometriosis between surgery and no surgery or placebo. So we will have data on this topic in a few years, I think.
Yes. Well, thank you very much. No, I want to maybe provide a challenge to this. Again, reminding ourselves that what we do is evidence-based medicine. And evidence-based medicine has three pillars. One is the best scientific evidence. Two is the surgeon's or the doctor's experience and understanding. And the third, and the most important, is the patient's expectations and understandings. My patients, when they know that there is a possibility that they have an abnormality inside their body, and I say to them, this research has shown that maybe superficial endometriosis, assuming that the RCT will confirm that, and we don't know that. Their expectation is that they don't want to have that abnormality in their body. Now, there is one side of argument that says, when you are planning, a population-wide strategy, when to operate and when not to operate, it's one thing. But when it is me as a person sitting in front of you, convincing me that, let's just give you medications, my experience has been that patients always want to have their disease removed if they are very symptomatic and have not answered. What has your experience been when you talk to your patients?
I agree with you when you say we have to talk with patient because they have to have the last word. They decide. It's easier for me when I see something and I can tell her there is something, there is a nodule, a lesion visible at MRI or transvaginal ultrasound. Also, if you want, we will remove it, but I don't guarantee the the pain improvement. So, and I many times I explain the cofactor of the pain. So when I see a woman with great lesion, awful lesion, and I say that maybe surgery will make it better. But when I intermediate lesion, I explain there might be other factors. So I search for sensitization, and sometimes I go, I send the woman to a medical doctor with a pain doctor. So, and we will talk with the pain doctor and say, you must, maybe it will be good to do the surgery. And sometimes they say, we will try other
Yeah.
approach like painkillers and so on. So it's
Yeah.
depend. I
Yeah.
always do what the woman wants, but I may take many times, many consultation for for some women it takes 1 or 2 years
Yeah.
because I said we will try that and then we will try that and then
Yeah.
we will choose the operation.
Exactly. I think you make a very important point, Arno. I completely agree that if we reassure our patients right from the start and spend time with them to say that, number one, endometriosis is very complex and it's rare that we only have one cause for all your problems. Okay. It's always multifactorial, even in the worst case of endometriosis with a huge nodule and adenomyosis and everything there will be other factors involved. And my strategy always is to explain to my patient that surgery, even if we did surgery, is only part of the solution. You know, we are going to have to tackle this problem from all angles. And then, even in cases where I don't think that surgery as the first line is the solution, I always reassure them that, look, this is not to say that surgery is not an option. It just means that we need to work together to understand what works best for you and believe the patient. This is the important thing because sometimes, maybe in
Yes,
the previous generations, we haven't believed our patients. We have taken a form of telling them no, but that research showed that this does not cause pain, and therefore I'm not going to operate on you. This is not the language that
yes,
our patients want to
yes.
hear. Um,
I agree with you. We have to believe them, but we have to counsel them. So
yeah,
it might be different. So when I see with I was very um, surprised that in the group we without any signs of visible endometriosis we have 90% of endometriosis lesions. So when you tell a patient do not do surgery, come and see me in 6 months, try this pill, try to do acupuncture or hypnosis or so. And then she go to the clinic near from me and just have laparoscopy and removal of endometriosis. And so happy and say, I had endometriosis. So the problem is to take the patient in your side. I mean, when you think, because you have an idea when it will work and when it won't work, so you have to have tools to assess your opinion. So, I mean, you have to evaluate the patient with questionnaire. We use, as Yasmin has shown, we use systematically questionnaire, and they are not little questionnaire. They are 20 page questionnaire, and they like to do that. And we also use tools to detect sensitization, and we talk to the patient before surgery for 2 to 7 times before doing surgery. So I think we have to keep the patient with us, and as you said, we don't shut the option of surgery, but we have to keep with us, because because if you don't explain why you don't want to do surgery, she will have surgery by a colleague who will have 5 minutes to say, oh, we will operate tomorrow very quickly, will be everybody will happen. So it's difficult to keep the patient when you don't want to do surgery. So it's my problem, I think. It's my
Well,
problem.
with that, I wish we had more time. This is a fascinating discussion. Arno, I want to especially thank you because I know that um, it was you made a lot of effort to make this happen, even though you had other things going on and normally wouldn't be possible, but you made it happen, and I'm very grateful to you. And Yasmin, we welcome you and thank you for the time that you've taken and very nice brief presentation that was to the point and said exactly what we wanted to hear, very nicely delivered. And I thank Oscar for organizing this and Ben for being here and to have helped in the previous years with the Legendo running. I wish all of you, the audience, the very happy Christmas, although we still have another
Thank you.
20 days to go. But with that, I thank you very much, and we'll see you on the 6th of January.